And welcome back, everybody. This is our Learnings from Natural History Cohort Studies section. So we will start off with Jennifer Barbadora, who's going to present on bone density screening and vascular Ehlers-Danlos syndrome.
So hi everybody. My name is Jennifer Barbadora, and I'm a pediatrics resident. I'm at Baylor College of Medicine in Houston, Texas, and I'm really happy to be here today with you all. And a special thanks for the opportunity to present our research. So vascular Ehlers-Danlos syndrome, VEDS, is caused by mutations in COL3A1, and it's the highest risk form of EDS due to arterial and organ complications. It is part of a larger group of connective tissue disorders, including osteogenesis imperfecta, where the risk of bone involvement and fracture rates and higher risk of fractures is well known. Many forms of EDS have been associated with low bone density. And on review of the literature, it appears that it's very specific for different types of EDS and seems more related to the more rare types of EDS, particularly kyphoscoliotic and spondylodysplastic EDS, which have been associated with bone fragility and fractures. In an unpublished study of adults with VEDS, we found that it was found that 6 out of 12, 50% of their cohort had osteoporosis, and another 6 out of 12 had osteopenia. So the objective of our study was to evaluate bone density in children and young adults with VEDS. In our institution, bone density evaluation using dual energy X-ray absorptiometry, DEXA, became standard of care for baseline evaluation of patients with VEDS in 2019. Our study is a retrospective review of a cohort of patients less than 35 years old. Our inclusion criteria included patients with documented COL3A1 genetic testing, a documented DEXA scan, and evaluation at our center in a clinical or research capacity. There were no exclusion criteria. Z-scores were calculated based on age, sex, and race match controls. They were compared against the expected population value of 0 for each region tested using one sample Wilcoxon signed rank analysis. And the regions tested included the femoral neck, lumbar spine, and total body excluding head. We also compared the Z-scores compared based on genotype, which were classified as splice site, glycine missense, and null variants. We had 19 patients undergo DEXA testing, for which the percent male was 89%. The median age at testing was 10 years old with a range of 5.1 to 33.4 years. We had 53% Hispanic and 47% non-Hispanic white in the cohort. In terms of genetic variants, we had 58% with a splice site mutation, 32% a glycine missense, 5% a nonsense, and 5% a multi-gene deletion. And of note, for the patient with a multi-gene deletion, there were Z-scores that were far outside our expected range, so we excluded them from further analyses in terms of creating medians for the analysis. Indications for 95% of the patients were for surveillance, and for one patient, it was for frequent fractures, and 21% of our cohort had a history of fractures. So this slide is depicting the median DEXA Z-scores by body region. So to provide some orientation, along the x-axis, femoral neck, lumbar spine are Z-scores, which are a continuous variable displayed from positive 2.0 to negative 5. And the dotted line around 0 is the cutoff that we're using, given a normally distributed population would have a median at 0, where half of the values would be above this line and half below. As you can see, just looking at the plot, the majority of our Z-scores are below 0, so lower than would be expected. And the medians for each, going from left to right, and the medians are displayed at the top of the graph, is negative 1.35 for the femoral neck, negative 0.50 for the lumbar spine, and negative 0.40 for the total body. And we have statistical significance with a p-value less than 0.05 for the femoral neck. In this next graph, we dichotomize the data with z-scores less than or equal to -2, and then z-scores that are greater than -2. The significance of those z-scores that are less than or equal to -2 is that these z-scores are consistent with low bone mineral density. As in the prior graph, the regions evaluated are along the x-axis, and along the y-axis is the percent of the group with a z-score less than or equal to -2. And just to note, the dotted line at the bottom is at 2.5%, which is the expected abnormal values below that number for a normally distributed population. So starting at the femoral neck, 29% of the group had abnormal z-scores less than or equal to -2. At the lumbar spine was 16%, and at the total body, 25%. And when looking at our whole cohort as a group, total of 5 patients out of our total of 19 had an abnormal z-score in at least one of the regions that was tested. And this graph is depicting the median DEXA z-scores by body region and genotype. So similarly as in the prior graph, the regions tested are along the x-axis with the median z-scores right above those titles. And then on the y-axis, the continuous variable for the z-scores is depicted. Again, we use the value of 0 for a normally distributed population. In this value, the glycine mutations are shown in orange and the splice sites are seen in blue. We can see that the majority of the z-scores again are below 1, so lower than we would expect. And in comparing between the two, it does look like the splice site mutation generally has lower z-scores at the femoral neck and lumbar spine compared to the glycine mutation, but the difference between the two is not statistically significant. And comparison between the two at the total body is they both had median z-scores at both at -0.4. And then comparison in terms of statistical significance, we do see it at the site of this glycine mutation tested at the lumbar spine, and that was our highest value group in that portion of the plot. In terms of, we decided not to do the dichotomous assessment in this case due to the lower number of subjects that were in this, but wanted to give an idea of what the z-scores were looking like based on genotype. So kind of based on the results of our studies, so we see low bone density more frequently in this cohort than in the general population. And as mentioned, about total of 26% of our cohort had z-scores that were consistent with low bone mineral density. And in general, our median z-scores for each of the regions tested were less than 0, so lower than we would expect. And we don't see statistical significance throughout the plots, which we suspect is due to the low population size and low power. So continuing to assess patients in the future would be helpful for this. And we think that we may see low bone density in VEDS specifically due to the role type 3 collagen plays in bone. It's found in the type 1 containing fibrils, and studies have suggested it has a role in trabecular bone development. And it's important because numerous studies have emphasized an inverse relationship between bone mineral density. Our population DEXA scans are quick and non-invasive and really a low radiation option, which are all really important qualities for evaluating a pediatric patient. So in conclusion, our study has long-term implications for diagnostic and therapeutic strategies in caring for patients with VEDS. In general, pediatric reviews recommend optimizing bone health with age-appropriate vitamin D and calcium, and then physical activity within the child's limits. And in other cases, drug therapy can be considered as well. But certainly, based on the results, we feel that integrating bone density evaluation into this population's clinical care should be considered. So thank you all for your attention. I apologize for the technical difficulties, but we can take questions at this time.
Hi, I'm Anne Legrand from the European Georges Pompidou Hospital in Paris, and I'm going to present our project entitled Aortic Involvement in Vascular Ehlers-Danlos Syndrome, a retrospective multicentric cohort. This work is in collaboration with the French VEDS group, the network of reference centers in France, Rosa Maria Bruno and Pierre Bouchery from the Department of Pharmacology of our hospital, who performed echotracking data for a subset of patients. Sorry, I have a problem to change the slides. Okay. The question of a higher prevalence of aortic lesions in haploinsufficient VEDS patients remains open. In the literature, 2 publications reported a higher prevalence of aortic complications in VDH patients. In the first one, describing an American monocentric cohort of 68 patients by Sherin in 2014, the group with haploinsufficiency had a higher incidence of aortic pathology than the group with dominant negative variants. See 56% versus 21% with a significant p-value. In the second one, from our group, describing the French multicentric cohort of 215 patients by Michael in 2015, aortic complications were more prevalent in patients with haploinsufficiency when compared with glycine substitution or spliced variant. And the result was also significant. Thus, the aim of the study was to describe the prevalence of arterial lesions and more specifically of aortic events in our French cohort. VEDS patient referred to the French National Reference Center for Rare Vascular Diseases in European Georges Pompidou Hospital or to the corresponding network of reference centers with a confirmed molecular diagnosis and vascular assessments were included in this retrospective cohort study. Among the 330 included VEDS adult patients, 59% had glycine missense variants, 22% had spliced variants, and 19% had haploinsufficient variants. Medium-sized artery or aortic lesions were reported in 242 patients, corresponding to 73% of the cohort. They are distributed as follows. 198 patients had medium-sized artery lesions alone, 9 patients had aortic lesions alone, and 35 had both. In each group, a carotid echotracking was performed in a subset of patients. Among the 242 patients with arterial history, 233 have medium-sized artery lesions. 56.6% patients have lesions in limb arteries, including iliac and femoral arteries, distal arteries of the upper and the lower limbs. 56.2% have lesions in supraortic trunks, 46.7% in digestive arteries, including celiac trunk, hepatic and splenic arteries, mesenteric arteries, and gastroduodenal arteries. 44.6% in renal arteries, and only 2.5% in coronary arteries. The comparison of the occurrence of medium-sized artery lesions in dominant negative and haploinsufficient groups show a significant higher prevalence in dominant negative patients with a p-value of 0.0011. When we look at the localization of medium-sized artery lesions in more details, this significant difference remains only for supra-aortic trunks and renal artery lesions with a p-value of 0.002 and 0.003 respectively. Now, when we look at the group of 44 patients with aortic lesion, the prevalence is almost twice as high among the haploinsufficient group with an almost significant p-value of 0.05. This difference disappears after age at molecular diagnosis adjustment with a p-value of 0.59. Therefore, aortic events are probably due to the older age of haploinsufficient group. A logistic regression model was built in order to explain the occurrence of aortic events in VDS patients, including demographic characteristics, variant group, and cardiovascular risk factors. Males are more at risk than females for aortic lesions with an odds ratio of 2.19, whereas relatives seemed spared from this complication with an odds ratio of 0.41. Moreover, the later the molecular diagnosis is made, the higher is the risk to have an aortic lesion, with an odds ratio of 1.07 and a significant p-value. This association is likely to be caused by the higher age of patients with haploinsufficient variants. The two other explanatory variables at this study, including cardiovascular risk factors and type of variant, were not significant. In a subset of 134 patients, a carotid echotracking using a high echotracking device with ArtLab technology was performed and provide the measure of the Young modulus of carotid elastic modulus to determine the elastic properties of the wall material. There is a significant difference in the carotid elastic modulus in patients with dominant negative variants in comparison with patients with null variants after age, sex, and mean blood pressure adjustment, with a p-value of 0.005. The lower carotid elastic modulus in dominant negative group could explain the higher prevalence of supra-aortic lesions observed in this group. In conclusion, whereas the prevalence of aortic lesions is not influenced by the COL3A1 genotype after age adjustment, patients with dominant negative variants have a higher frequency of medium-sized artery lesions, and specifically renal and supra-aortic lesions. The latter is associated with a lower stiffness of these arteries. Thank you for your attention.
Great work. Thank you so much for sharing that. Any other questions? All right, so I will go next. I'll give you an update on our cohort here in the United States. So this is an update on year one progress in our comprehensive natural history study. As you're all aware that one of the challenges is obtaining the medical records. Can we mute folks who are not speaking, please? And can you mute yours? And anyway, so again, the whole point is that the bias in the literature is related to people with severe phenotypes, and this is why all these natural history studies are really important. When we started this journey, hold on one second. Katie, are you able to mute Anne's mic?
Yeah, I'm trying to find her.
Thank you.
It's not letting me mute her.
She did it. It's good now. Thank you.
Okay, you're welcome.
So the two elements that we wanted to address were, one is we really wanted a comprehensive knowledge of the natural history, and we wanted patient input into the research priorities. So as you recall, we presented this in the past at this group, actually, this last meeting, where we discussed the research priority, the vascular EDS collaborative research priorities. And you can see that barriers to care, exercise, pregnancy, and screening and surveillance, thank you for muting that, and VEDS treatment were the priorities, and we have published those. And I'm highlighting in the orange colors here, the pregnancy and the VEDS screening and surveillance, which lend themselves very well to the natural history study. So I will give you an update of where we are. We started with a very humble beginnings, really asking patients to help us raise the funds to do this study, in addition to applying for foundational grants. You can see a lot of people have donated small and large amounts, and we're going to report back to the community because this is really their investment in this study. And we started recruiting, and everybody with a molecular confirmation of vascular EDS was a pathogenic, likely pathogenic, and including VUSs are eligible for enrollment. And I'll talk a little bit more about the consent. But most importantly is that the patients and the families were engaged as research partners and helped us design this, including the flyers and the dissemination and the recruitment. So we recruited patients from the VEDS Collaborative Research Network, as well as clinical visits, and advertised on social media groups, including through the VEDS movement, the Martin Foundation, and the Ehlers Danlos Society. And then along the same time, because of the feedback from the community, we moved from the traditional consent forms to DocuSign. And fortuitously, if you will, sort of an interesting coincidence that COVID also had pushed people away from having to have in-person meetings. So the rollout of the DocuSign was actually quite handy at that time to allow people to still enroll even at the height of a pandemic. The other evolution that is helping this is that eCare via Epic, which Epic is the electronic medical record format that can communicate with any other hospital in the United States that has records, and I actually found out recently that we can also communicate with Canadian hospitals who use Epic platform. So we're able to access medical records that way once we have the consent from the patients. And then we also ask the patients to help us fill in the missing details to have complete records as complete as possible. And so to date, we've enrolled 232, and as of this morning, it's 236 individuals with genetically confirmed vascular EDS. And at the time when we pulled this data together, just as a brief overview, we had 192 patients with pathogenic and likely pathogenic variants that are enrolled. 65% are female, and we were able to abstract up to 2/3 of those records. And of those records that we've abstracted, it showed that we have 258 arterial events, and this is a mix of aortic and arterial. If you were to look at the variant distribution, you can see that the predominant population so far have glycine substitutions, but we also have a reasonable amount of patients who have null variants as well, which is higher than what we would have anticipated. So that's actually great. It goes back to this idea that patients with null mutations perhaps were not coming to attention, and now we're seeing more of this population coming to attention. And then another larger group, subsequently is also the splice site groups. At this point, I will ask Katie to stop the recording. So our next steps now is we're going to continue basically moving this data into a REDCap database and harmonize it with Dr. Byers' cohort, which has 16% glycine substitutions. And this is the original cohort that was published. And also we're going to reach out to their physicians who enrolled them to see if we can track these patients and find them and ask them to please enroll. Obviously, we'll continue asking the community to bring back this to the community and ask them to help us as well enroll to increase the numbers. But we're accumulating a large body of literature and really expanding our collaborative network. The data set, we're happy to abstract data by if people are interested in specific projects. We're happy to abstract that data and help, if they can help us analyze and look at these and from different facets. I'm definitely looking for a GI surgeon who's interested in looking at the intestinal complications. I've been trying to work with somebody, but Enid Neptune and, for example, is working on the pulmonary component. Shane is on kids. Melissa Russo is on GI complications. So the more the merrier. We can get a lot more done in a shorter amount of time. So this is obviously possible, and it couldn't be possible without the collaborative efforts and the involvement of the patients in this work. And so for that, I'm very appreciative and very thankful. So thank you for listening to this. I'm going to stop sharing here. All right, so our last speaker had to step away, but they recorded their call. So this is Juliet Harris. Her call is recorded. Her presentation is recorded. And the title is Stoma Reversal in a Cohort of Individuals with Vascular EDS, a description of 4 cases.
Stoma reversal in a cohort of individuals with vascular EDS, a description of 4 cases. Several people with vascular EDS in our service had a history of bowel rupture, followed by a Hartmann's procedure. This procedure involves sealing off the area of ruptured bowel, while the rest of the bowel is brought out through the abdominal wall to create a stoma over which a bag is fitted to collect the feces. This is often a temporary measure while the bowel heals, followed by further surgery, a stoma reversal, where the bowel is taken back inside the body and rejoined. Some of our patients who had had a Hartmann's procedure wanted a stoma reversal to improve their quality of life. However, their surgeons were advising against this due to the risk of tissue fragility. We were asked about whether we knew of patients who had had a stoma reversal and their outcomes. A review of our patients with molecularly confirmed vascular EDS revealed that 4 had in fact undergone a stoma reversal. 3 of the 4 did not have a vascular EDS diagnosis at the time of the reversal. For 3 of them, the bowel rupture occurred spontaneously, but for 1, it was following a colonoscopy. Post-operative complications following reversal occurred in 1 person who had an MRSA infection and delayed wound healing. It has now been between 10 and 28 years since stoma reversal for these people. 3 have ongoing gastrointestinal problems as shown on the slide. This small review has shown that for several individuals with vascular EDS, stoma reversal did not lead to major or life-threatening complications during or after surgery, and no reperforation has occurred. While the general advice will remain to avoid surgery unless absolutely necessary, further data from more individuals with vascular EDS and stoma reversal versus no stoma reversal is important to facilitate discussion around the management of bowel rupture. Thank you.